For our GI session, we'll be starting off with evaluation of liver enzymes. And our speaker is Dr. Elizabeth Carey. She's an associate professor of medicine here at Mayo Clinic, Arizona. She did her residency and fellowship here. She did fellowship training in GI and hepatology, as well as transplant hepatology.
Good morning. I'd like to thank the course organizers for inviting me to speak today. It's really a pleasure to be here. I'm really impressed with the turnout. You guys did a great job organizing. So I'm going to do kind of a general update in hepatology, and we'll do it based on a few cases. Hopefully everybody's loaded up on coffee right now, but in case you're not, I hope my questions will keep you awake. These are my disclosures. And this is somebody that one of my friends encountered a couple years ago. It's my job here today to tell you that the liver is not evil. It's really a very fun organ to take care of, and we have a lot of new treatments that we didn't used to have. So the first case, this is direct-acting antiviral therapy for hepatitis C. We had a 55-year-old woman. She had genotype 1A hepatitis C virus, treatment naive, and on transient elastography, stage 1 fibrosis. At baseline, you can see her labs. Her ALT and AST were minimally elevated, but nothing significant, normal alk phos and bilirubin. She was treated with ladipasvir sofosbuvir, that's Haroni. And then at week 6, just kind of routine labs were checked, and her ALT was over 1,000, and her bilirubin was 2.3. So what is the most likely cause for the rise in liver enzymes? Is it a flare hepatitis C on DAA treatment? Reactivation of hepatitis A, reactivation of hepatitis B, an autoimmune hepatitis that's triggered by the direct-acting antivirals, or a nonspecific autoimmune response that we see with hepatitis C therapy. Okay, good. So the evolution of hepatitis C treatment really has come a long way in my career. When we first really talked about this disease in the early 90s, we started off with regular interferon, which was given 3 times a week, and we had about a 16% response rate or 16% cure rate. And then came ribavirin, which we used with interferon, then the pegylated form of interferon, and we were kind of getting incremental gains with each of these new developments. About 8 years ago, we had the first protease inhibitors. We had telaprevir and boceprevir. And then we could get a 70% response rate using pegylated interferon